All right, this meeting is being recorded. This is the June P&T committee meeting. Welcome to everyone. We're going to get started. So we have some general announcements and guidelines on the screen in front of you. We've made the committee members co-hosts so that they're able to mute and unmute their lines so we can conduct business. So if you are following along in the audience and where you found the link to join this meeting, we have posted the packet of materials and written testimony. So I'm going to call out the page numbers if you are following along on that. We're going to start off with roll call and introductions, but I wanted to start off first to introduce to the committee. As you know, Dr. Jeannie Savage left the committee. She's doing some important work with one of the subcommittees with the Health Evidence Resource Commission. And we were lucky enough to find Dr. Bruce Lee Wiwan Tanakul. I hope I got that close, Dr. Bruce. He's a child and adolescent psychiatrist at OHSU's Dornbecker Children's Hospital, where he provides evidence-based care for young people experiencing mental health concerns. He's known as Dr. Bruce by the patients and families he works with. Training in both pediatrics and psychiatry, he brings a thoughtful, comprehensive approach to patient care and collaborates closely with patients and families. And Dr. Bruce also serves as an assistant professor at OHSU, helping train the future child psychiatrists. His expertise and balanced clinical perspective make his contributions to Oregon's P&T committee a welcome and valuable addition. That lovely introduction was written by Trevor. He was unable to be here, but Dr. Bruce, if you want to take a second and add what you will or introduce yourself to the committee.
Thank you. I'm Bruce. I am a child adolescent psychiatrist. I also trained as a pediatrician before. I'm happy to be here and help in any way I can. Thank you.
Really appreciate you joining this great P&T committee. Yep, Doug, agreed. So very open process. Stop us, ask any questions as we go along. We try to bring your attention to the packet of materials. So with that, we're going to do intros for the entire committee. Bridget wasn't able to join us. Tim, as you saw, was here for a moment, but has not with us. Dr. Stephen Samara also is not with us. So Doug, we'll turn it over to you.
Sorry. Douglas Carr. I'm an internist by training. I'm a medical director at Umpqua Health in Roseburg.
Welcome, Doug. Russ?
Hey, I'm Russ Huffman. I'm a psychiatric nurse practitioner at Salem Health.
Welcome, Russ. Dr. Onishi not able to join us, so Eddie, we'll turn it to you.
Hi, Eddie Saito, Associate Professor at Pacific University School of Pharmacy and clinical pharmacist with Virginia Garcia.
Welcome, Eddie. Pat, up to you.
Pat DiMartino, faculty, OHSU Peds HEMOC.
Welcome. Unfortunately, Jen isn't able to join us either, so Stacy, who's our chair right now, please leave it to you.
Hi, this is Stacy Ramirez. I'm actually not sure exactly how to introduce myself right now because I'm in the middle of a couple of transitions. So I'm a clinical pharmacist doing some consulting work right now in the ambulatory care space. And welcome to the new committee member.
You bet. Thank you, Stacy. And for staff, I didn't see Jennifer, so I'm Roger Citron. I'm the director of the Drug Use Research and Management Group. We're out of Oregon State University College of Pharmacy, but we're dedicated to our work for the Oregon Health Authority, supporting this P&T work and clinical pharmacy support in general. Trevor was not able to join, so Dave, we'll turn it over to you.
All right. Hi, I'm Dave Engen, a clinical pharmacist with the OSU Derm team.
Hi, I'm Sarah Fletcher. I'm one of the P&T clinical co-coordinators with the OSU Derm team.
I'm Andrew Gibler. I'm the clinical pharmacy policy and programs manager for the Oregon Health Authority.
And Dan isn't joining us, nor is Megan today. So Deanna, we'll turn to you.
Good afternoon. I'm Deanna Moretz. I'm one of the pharmacists with the Drug Use Research Management team based at OSU College of Pharmacy.
Hello, I'm Kathy Centena. I'm also a clinical pharmacist with the OSU Derm team.
Hi, my name is Sarah Servid. I am one of the P&T clinical coordinators with the OSU Derm Group.
My name is Lan Starkweather. I am the pharmacy manager at Gainwell Technologies.
I'm Dee Weston, Pharmacy Program Policy Advisor at OHA.
Good afternoon. My name is Brandon Wells. I'm the Pharmacy Program Policy Operations Analyst at OHA.
Hi, welcome everyone. My name is Michael Yu, pronouns he, him, his, and I'm the OHA Community Pharmacy Liaison. Thanks, Roger.
Thank you, Michael. So as you see, we have quite the team that's helping to make these meetings come off with a hitch and provide the evidence. So if you're following along in the packet, we'll next go to the approval of minutes on page 5. First, I want to talk about conflicts of interest. So all of the staff have conflict of interest declarations on file with the OHA, as do all the committee members. It's very important that those conflicts, one, that we try to avoid them, but if one occurs, that is brought to the attention of the committee or members recuse themselves from any discussion. So we always start the top of the meeting off to see if there are any conflicts that a committee member has not had an opportunity to disclose to the OHA, to give you a chance now. Hearing none as expected. We also, when people want to provide public comment, we have them fill out our conflict of interest declaration, and I'll bring that to the attention of the committee. Generally, if it's a member that's representing industry, I'll just make that statement, and that sufficiently lets the committee know that they are working for that company. So again, turning it over to page 5, I had sent out the minutes in advance to the committee. So are there any edits that need to be recommended? And if not, we would entertain a motion to approve.
So moved.
Thank you, Doug.
Second.
Thanks, Pat.
All those in favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you.
And I'll mark Dr. Bruce as abstained just because he was not a part of the committee's deliberations at the April meeting. So next we'll have a department update. So I'm going to turn it over to Dee.
Yes, sorry. It took me a moment to come off mute. And then I immediately put myself back on mute. I just wanted to call out, I think, just one item to make sure everyone is aware that members who are eligible for Oregon Health Plan or OHP through the Healthier Oregon program will transition to Open Card or Fee for Service, same different name for the same thing, effective January 1, 2027. This is required due to recent federal policy changes. Healthier Oregon, as of February 2026, covers about 97,000 people in Oregon through the Healthier Oregon program, and about 98% of those are enrolled in a CCO. They will all be moved over to Open Card or Fee for Service. So that is a very significant increase in Open Card enrollment. Roger and his team has done a lot to try to get ahead, to work through different kinds of challenges of all sorts. And I am also working with CCOs to try to facilitate that transition. That is what I had. Is there anything else that anyone from OHA should want me to add, or Roger would like me to add?
I think that covers any questions from the committee for Dee.
Yeah, this is Eddie. What was the effective date again?
January 1, 2027. Yeah.
So we are doing quite a bit of work trying to look at claims, and it'll be a recurring theme on today's agenda. So we'll be getting into that more. And as well, it's something that we'll be discussing with you when we're looking at pricing in executive session, because it shines a different light on some of our considerations. So
it does.
Any other questions? Yeah, for Dee? All right. Thank you, Dee. And we'll turn it over to Andrew for the mental health clinical advisory update.
Thank you, Roger. The Mental Health Clinical Advisory Group is composed of 18 members, mostly practitioners with mental health experience and expertise, in addition to consumers and mental health advocates. And we are actively looking for a couple of new members. One is active practicing psychiatrists, typically adult psychiatrists. We do have child and adolescent already in the group, and so we would like an adult psychiatrist. If anyone on the committee is aware of one person that may be a great fit, please have them reach out to me. The person currently in the group is retiring and working hard to try to find a replacement. We are continuing to look though. So we're also looking for a representative of a coordinated care organization, preferably a physician or pharmacist, and one who lives and works in Oregon that can represent CCO perspective when it comes to mental health treatments. And then we're also looking for an individual that's representing a statewide mental health advocacy organization for people with mental illness who either has experience themselves as a consumer of mental health services or has a family member who is a consumer of mental health services. So if the committee can think about ways we could recognize any individuals that may be potential candidates, please again reach out to me. The group meets every 8 o'clock every first Thursday of every month. So we met this morning, and the latest update is they approved treatment guidance for adults with ADHD. So please go to our website for all our recommendations that have been published. This one should be published next week, and it'll likely be incorporated into a future review of ADHD drugs when the DERM group looks at that drug class again. So I think that's all I have.
And the best way to
yes.
reach out to you, Andrew, should they just go through the listserv email address on our website where they have this link, or how would you like to?
That is all. Many roads lead to me eventually through Roger's team, or you can email me directly or OHA directly. My email is all over the website for the Mental Health Clinical Advisory Group. If you put that in your search engine, it'll come up. So
fantastic.
Yeah, thank you.
You bet.
Appreciate
Thank you. Any questions for Andrew? Okay. If you're following along in the packets posted, we're going to the consent agenda. The first 3 topics start on page 9, but we have the consent agenda so we can add drugs to our policies, both oncology and orphan drug. And when there's no new evidence in a given review, that we're planning just to review an executive session. So this time we'll see if anybody wants to pull any of the topics off of the consent agenda to discuss. If not, we would entertain a motion to approve the clinical recommendations.
Motion to approve.
Second.
Pat. Thanks, Russ.
Do we have a second?
We did that. We had Russ.
Perfect. All right. All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? Thank you.
All right. Turning your attention to page 48 in the packet of materials, we'll do PDO old business with the Healthier Oregon policy update and turn it over to Sarah Servid.
Thanks, Roger. So just building on what Dee presented a little bit earlier, this transition that's going to happen at the beginning of 2027 for Healthier Oregon participants moving into fee-for-service will change how we look at drug pricing a little bit in the open card or fee-for-service program. The majority of drugs that are paid for Healthier Oregon members are not eligible for federal funds or for Medicaid drug rebates, unlike most participants in Medicaid. In the Healthier Oregon program, only emergency services get federal match and are eligible for drug rebates. And by and large, drugs are not considered currently as emergency services. So the result of that is that we as a committee will need to look at a lot of our PDL classes and reevaluate which products we have preferred and non-preferred as far as looking at upfront cost instead of cost net of rebates, because we will have a large portion of people in the open card or fee-for-service program that are not eligible for those rebates. And so we have been working as staff to streamline how we're going to bring you all reviews. What we have settled on is bringing back classes that we've reviewed recently as old business and not conducting a new literature scan. So bringing things that have been recently reviewed back as old business just to look at pricing. If anyone has questions about new evidence in any of these classes, please do speak up. If you're aware of any new evidence that would change PDL recommendations or PA criteria that's been published since the last time we reviewed the class, we can take a deeper review or deeper look at that particular class. But then we'll also be bringing back streamlined reviews, literature scans of things that haven't been reviewed recently, so that we can make PDL decisions based on any new evidence and then also based on costs in the absence of any evidence for efficacy and safety between drugs. So that is, in a nutshell, how we plan to tackle reviews for this policy change of Healthier Oregon participants moving into fee-for-service or open card. So for this meeting, we'll be looking at 6 different classes that we have reviewed within the last 2 to 3 years and evaluating costs for these classes in executive session. But I'm happy to take any questions people have about process or how we're planning on handling this.
Good job, Sarah. Thank you. Pretty straightforward process. Again, we're trying to make sure we have the evidence as we always do, efficacy, safety, and then costs. In this case, we're trying to chip away at this large body of reviews that need to be done, building upon the work we've previously reviewed, and we'll look at it in Zec. So no questions for Sarah? All right. Well, as the committee knows, you also serve as our DUR board. So we take one meeting each quarter and focus on DUR activities. If you're following along in the packet, we'll turn your attention to page 49 in the packet. And so this is a report most of the committee has seen. Dr. Bruce, is maybe first time for you, but it includes both fee-for-service and Encounter information. Encounter represents our CCOs. So you can see it's 6 months old, the data, and that's a reflection of both Encounter data, timeliness to get that into the system so we can pull data from it and draw reports, and also because of rebates. You know, we finish a quarter. So for example, at the end of May, the first quarter of 2026, January through March, was invoiced for rebates by Gainwell. So because rebates are also included in here, we look at some expenditures and utilization. That's why you'll see September of 25 as the last month up there. But we have the rolling average so you can see the totals. And these reports, these quarterly utilization reports, are out on our website. So you can go and look at the historical reports and make comparisons. It breaks down, you know, both the mental health carve-outs, because that's paid exclusively by fee-for-service, as well as the fee-for-service versus Encounter data. Next page. So again, there's additional information. We have the pie charts, nice eye-catching in the middle, and the next page will show some of the rebate information. So over time, this is reported on a quarterly basis because that's how rebates are invoiced, and that second quarterly net drug costs takes that information from expenditures and overlays those rebates that are collected, which are quite significant, as you can see, and it looks at what our net drug costs are. We break these out by both federally mandated rebates and supplemental rebates that are negotiated, both supplemental rebates on fee-for-service utilization, on the carve-outs, and then also we have some supplemental rebates offered on our CCO utilization, so those Encounter rebates. Next page. So again, some granular detail. We're looking at changing these reports just to have more of a reflection of fee-for-service, and especially with some of the different populations we have, particularly as we look at the HOP population, how these reports may best inform the OHA and also kind of be transparent to the public. So these currently are the reports we've been running with, so we will make that transition, but it talks about generic percentages, preferred drug use, costs for physician-administered drugs. Again, some of these are starting to get out of whack if you're looking to make a comparison, for example, because of the high-cost drug carve-out. So that's going to make the fee-for-service numbers look inflated. So there's really not an apples-to-apples comparison that's this lends itself towards. Where we have made some initial changes are coming up in the next pages. So we have our, as you know, the top 40 lists. So we have the top 40 mental health carve-out drugs, since this is paid by fee-for-service for the entire OHP population. And again, things that have an asterisk, we have supplemental rebate contracts. You can see the number of claims that are associated, the amount paid per claim. The far column is, yes is preferred, V is voluntary, non-preferred, since we don't currently enforce the PDL. And if there's a blank, that means there's no PDL status for that. And the next page, we have the overall top 40 drugs. This is a new page. So here's the carve-out drugs. So the high-cost carve-out. So you can see where we're starting to get utilization in that claim count. I will caution that these numbers, we're doing some work on the amount paid. These aren't an accurate reflection right now, so there's some internal workings that we're doing. Some of these are too large, the number of decimal places, so we have to make some system changes, and also our reimbursement in the system is being worked on. So don't focus too greatly on the amount paid, because over time I think there will be some changes, but nonetheless this does reflect those drugs that have been carved out and are being paid exclusively by fee-for-service. Next page. And then we have the physical health drugs. So these aren't carved out. So this is just the fee-for-service population. And you can see where we're spending the bulk of our funds and the number of claims. So breaks down overall. At the bottom, you can see the overall total spend and then what percentage these top 40 drugs represent as a percentage of that spend. So with that, I don't think there's another page, is there? No. So are there any questions about the quarterly utilization report? Typically, and going forward, this will be part of the consent agenda. We don't get into it. Obviously, it's published on a quarterly basis, and we include it in the packet one meeting every quarter. But we do focus on the other DUR activities. So I'm not seeing any questions from the committee. So we did make some minor modifications to our P&T methods and procedures. So Sarah, I'm going to turn it over to you. Starts on page 56 in the packet.
Yeah, thank you. And so these changes reflect kind of the changes that we'd expect starting in 2027 for the fee-for-service population. And so the first change that we're making is removing the abbreviated drug reviews that we had sometimes performed for unfunded conditions. As you are probably aware, there will be changes to the prioritized list starting in 2027, and there will no longer be unfunded conditions. And so we're just deleting that type of review from our methods. And then again, we're trying, with regard to Healthier Oregon and the bulk of work that we have to do for that population before start of 2027, we've added some language here to hopefully streamline the literature scans that we perform for this committee, make them a little bit shorter, abbreviated, not do a full quality assessment for the literature that we identify. If we do identify literature that might change PDL status or PA criteria based on clinical information, then we'd incorporate that into a class update rather than putting it as a literature scan. But if we do an evidence search and don't find any literature that we think would change the current policy based on clinical information, we'll incorporate that into a literature scan, and most of those will be included in the consent agenda going forward. So hopefully that will help us handle the workload that we need to complete before start of 2027. And then again, because high-cost orphan drugs for very rare conditions have been carved out of coordinated care organizations, we've also added this orphan drug evaluation as a review type. It's kind of a streamlined new drug evaluation for some of these high-cost carve-out drugs. And that is the bulk of the changes as far as methods. You'll see similar updates in the PNT procedures, so reflecting those changes. But if the committee has any questions, feel free to let me know. And that's all I had.
Thank you, Sarah. Any questions about the proposed changes that we'll be implementing to streamline our processes? All right. Next, we have did you go over the procedures as well, or is that next on page 76?
I went over the procedures as well. There are,
I'm sorry, I'm multitasking.
Yeah, that's all right. There's similar changes as to what is in the methods and evidence summary.
Awesome.
Maybe just to take hopefully a moment to like think about in the procedures section, something I've always struggled with is when there's kind of a high cost therapy with marginal evidence for benefit, that I think it gives some of us a fair bit of moral distress as we're kind of hashing out PA criteria. And just to be explicit, like the value of the drug is not necessarily being considered in how we're creating our auth criteria, correct?
Agreed. Correct. Again, we have federal rebate law that when a manufacturer signs the rebate agreement, that provides that the state must have a pathway to coverage. So if it's FDA approved, even if they've lowered the bar and it's, we wish there were more stringent trials or demonstrating benefit instead of postulating that there might be some benefit, the best we can often do is have renewal criteria to try to establish, one, that they meet like the studied population, but two, that they're deriving benefit from the therapy if we're going to continue therapy. That gets even more problematic when it's a one and done gene therapy that may not have strong evidence, but it's the hand we're dealt, Pat. If we always make the statement that no state has done it, but coverage of prescription drugs is an optional benefit, but clearly every state's going to provide a prescription drug benefit. So with that comes the mandate that we have that pathway to coverage. And that does not entertain that value proposition.
Thanks. Just becomes all the more distressing with the high cost carve out now falling on the committee, but appreciate it.
No, I appreciate your question.
And I guess I would add, I think it is the committee's purview to determine medical necessity and appropriateness. And so that has to be framed within the context of what has been studied and what the FDA has approved. But I think that is what we're looking to this committee to do when we develop criteria for some of these orphan drugs, is really give us advice based on the evidence on what is medically appropriate and necessary.
Appreciate that, Sarah. Any additional questions? It's a great question, Pat. Okay. Well, as I mentioned, this is a DUR-focused meeting, so one of the first facets of that is prospective DUR. We have some reports from Lan Starkweather with Gainwell. I'm starting on page 82. Lan, the floor is yours.
Thanks, Roger. So Roger mentioned that this is the prospective DUR. This happens before the prescription is dispensed to the patient at the point of sale. This is a high-level summary of the activity for the quarter. Over on the first column will show the type of alerts that were hitting the system, examples of when those alerts would hit, and then whether or not we set to pay the claim. Majority of these are just informational. There are two which are highlighted in yellow, which is set to deny, and these will require pharmacist intervention in order to get the claim to pay. Very similar numbers for first quarter of 26 to the previous quarters. So a total of 185,000 alerts were processed. And then if we look at the early refill, which is set to deny, we had a 19.8% override. And then for the pregnancy drug interaction, we had a total of 181 claims that hit the alert, and then 74 of those were overridden. Next page. And here is the summary of the drugs that hit the early refill alert. These are weighted heavily towards the mental health drugs since those are carved out to fee for service. And I've just broken it down to the different types of category. So the first table is the SSRI antidepressants, about 17% overridden for the category. And then the other ones that we see a lot of is the antipsychotic, which is the third table. And then we see about a 23% override for those drugs as well. And then if you look at the fourth table, which is the anxiolytic, I included the benzodiazepine just so that we can monitor it a little more closely. Those have a higher percent of overrides because they are typically deemed more medically necessary. And that averages about a 27% override. And next page. And then here are the different reason codes for the overrides, just broken down to what the pharmacy enter in when they submit the override. So a majority of them, 71.6% is due to medical necessity. So they enter a submissions clarification code of 7. 14% is due to like an increase or a titration. And so that's why they would need to get the medication a little earlier than what the system will register. But overall for the quarter, 15,000 claims were overridden. Lastly, this is just the cost savings from the ProDer alerts. And this is when the pharmacy receives the alerts and just cancels the prescription and is not filled at a later date. So for January, we had 355 claims that were canceled, 84,000 in cost savings there. February had 409. Total cost savings almost 123,000. And then for March, only 80 claims were canceled. Total savings for that is 19,000. Overall for the first quarter, 227,000 saved. Any questions on the prospective TUR?
Thank you, Lan. Questions? All right. So the next facet of DUR is retrospective DUR that's performed by our team with claims data. If you're in the packet, it starts on page 86, and we'll turn it over to Dave Ingen.
All right, thank you, Roger. Yeah, once again, this is the first of a series of reports that contain the quarterly data on the various drug use interventions and outcomes for quarter 2. So that's January through March of 26. On this page, we've got the Billing Correction Review Initiative, and what we're doing there is we're keeping track of the high costs or the high dollar claims that might have been billed incorrectly for patients that might have other coverage. And so if we find incorrect billings, pharmacy is asked to reprocess the claim or claims, and then we can enter the savings manually. And in that process, we identified 103 potential claims total, where 19 ended up receiving a manual review. And when the dust settled, the claims weren't necessarily actionable. So we'll keep tweaking the program, and we'll keep you posted on the progress as we look for more opportunities there. On page 87, that's our provider alert to consider a change to a more cost-effective formulation. And we've been able to automate this and track cumulative savings. And the initiative continues to generate savings for desvenlafaxine, but really only modest savings for the aripiprazole rapid dissolve tabs. We've been eliminating the ones that haven't been generating much savings, but since these programs run in the background, we'll keep them going as long as there's a need. But once again, as you think of opportunities or hear of them, be sure to pass that along to us and we'll investigate. Page 88, that's our expert consultation referral for long-term antipsychotic use in kids. Looks like there was 981 patients screened, and there were 9 that were flagged as high risk. 7 of the prescribers received a referral to Opal K for a consult, and it appears that 6 of those patients ended up continuing with therapy. We'll go to page 89. This is our messaging to prescribers about patient non-adherence to their antipsychotics. And 74 patients were identified, you can see there, and prescribers were notified. About a third of the patients ended up getting a refill for their medication in the next 90 days after the prescriber was alerted. On page 90, it lists the different individualized profile reviews performed for children in foster care and for patients with a variety of high-risk conditions, so bipolar, polypharmacy, people on chronic opioids, etc. So as concerns are identified in each of these areas, custom letters are sent out to the prescribers with the clinical recommendations to encourage additional therapy or safer alternatives when it's available. Let's see the different numbers there. And then on page 91, that's our safety net program for antipsychotics in really young children. We send out reminders to prescribers to submit a new PA for their patient before it expires to avoid interruptions in care. And there we have 29 kiddos and 32 we have both 29 kiddos and 29 prescribers identified. So we're able to identify or notify 25 of those prescribers, and 20 of the patients had paid claims in the next 2 months, while overall, during that process, 13 experienced a denied claim along the way. Lastly, on page 92, this is where we report the safety net monitoring. The first one's for patients on dangerous opioid sedative combinations. Although there's a jump in patients identified, still roughly a third of those prescription combinations are being discontinued within the 3 months after they've been notified. We're also seeing new naloxone prescriptions being filled, so we're tracking that. And then average number of prescribed sedative drugs appears to be trending downwards. So you can also see on there were no oncology med denials. And then we do the same tracking for prescribers of kids on a TCA that had been denied, but no alternative was filled or requested. And it looks like there are 27 denied claims that were flagged, representing 14 pediatric patients, and 9 of the prescribers were notified. A couple of the patients ended up with a paid claim for a TCA in the following month. So, in general, that's our latest quarterly Retrodur report. And if any of this helped you think of new opportunities, please let us know. We can investigate further and get back to you once we dig into the data. But for now, if there are no other questions, I'll turn it back over to Roger.
Thank you, Dave. Any questions for Dave on our retrospective DUR? And again, to reiterate what he said, we're looking at claims data, and if we can pull information that identifies opportunities for us to improve patient care or quality, safety, please let us know. Ask the question. We can go research it and see if we can implement some other DUR initiatives. All right, hearing none. Third component of DUR is education. And one of the ways that we accomplish this is through our Oregon State Drug Review newsletters. And if you're following in the packet, the first newsletter, one of the more recent ones, starts on page 93. And Kathy Centena is our editor. So I'm going to turn it over to you, Kathy.
Great. Thanks, Roger. Yeah, so today we'll be recapping a couple newsletters. In November of last year, we published a newsletter on RSV prevention. This update summarizes current immunization recommendations from the Advisory Committee on Immunization Practices, and then also discusses products that are available for RSV prevention. And then the second newsletter was published in December of 2025, and it discussed evaluating the quality of evidence from observational studies and lessons learned from acetaminophen use in pregnancy. This newsletter describes key factors to determining the quality of observational evidence, such as study design, confounding control, exposure assessment, and outcome measurement, to assist the reader in critically evaluating observational studies. And so I want to thank so much to the authors who provide these important provider education pieces, and for the committee as well for providing feedback and suggestions on the newsletter. If you're interested in receiving the newsletter electronically, you can sign up on our website, and we recently posted our main newsletter on the West Coast Health Alliance. We also like to solicit the committee for newsletter ideas now, but then of course you can always email them to us as well. But if anybody has a newsletter idea, we'd love to hear it and look at publishing something on it.
Absolutely. During the course of the meeting, as we present topics, maybe new classes or drug evaluations, if you think it lends itself towards a newsletter that might be informative, please give us the ideas. So, all right. Great job, Kathy. Thank you. So we're going to start with our new business, starting on page 100 in the packet. And Kathy, going to leave it in your able hands for the first update.
Great, thanks, Roger. Yeah, so this class was reviewed actually to create a new PDL class for the type 2 topoisomerase inhibitor drugs, and then also look at any new evidence, because we did look at one of the drugs in August of last year. We also wanted to evaluate the evidence for the new drug zoliflodacin, a brand name Nuzolvanlin. Sorry, I don't know why I'm having trouble pronouncing that. But this class is comprised of two antibiotics, gepotidacin and zoliflodacin. Gepotidacin is approved for the treatment of uncomplicated urinary tract infections and uncomplicated gonorrhea, whereas zoliflodacin is just approved for the treatment of uncomplicated gonorrhea. Now, this class is kind of unique in that it does offer an oral alternative for gonorrhea treatment, in which usually first-line agents are intramuscular. It also offers an alternative oral therapy for those patients with severe beta-lactam allergies. So it is unique in that regard. So what we're going to look at today is there's several pieces of evidence identified. We're going to look at one high-quality guideline, one randomized controlled clinical trial, one updated indication, and then, of course, the new drug update. So just briefly, some background information. We know for uncomplicated urinary tract infections, these are usually treated empirically, guided by resistance patterns and likely organisms, usually E. coli. So guidelines do recommend first-line empiric treatment options as nitrofurantoin, trimethoprim sulfamethoxazole, fosfomycin, and pivmecilin. Now, for uncomplicated gonorrhea, the CDC recommends ceftriaxone IM first line and then cefixime as a second line option. Now, outcomes for both these indications are things like symptom resolution, microbiological cure, and then also, of course, with gonorrhea, prevention of complications, which can be severe, including irreversible infertility, as well as life-threatening infections if it gets into the bloodstream. So looking at our first new guideline, the European Association of Urology published a guideline in 2025. I'm going to briefly go over the first-line treatment options, but if you want to look at this in more detail, including like second-line options, this class is highlighted on page 103 in your packet. So for first-line options for cystitis or UTI, they do recommend pivmecilin, fosfomycin, and nitrofurantoin. The fluoroquinolones are not recommended for UTI unless there are no other antibiotic options that are appropriate. However, for other indications such as pyelonephritis, they are recommended. For urethritis, ceftriaxone and azithromycin are recommended first line. And then for acute bacterial processitis as well as chronic, they do recommend fluoroquinolones. I want to mention too that the type 2 topoisomerase inhibitors were not included in this guideline. So then looking at a new indication for gepotidacin, it did receive the additional indication in December of 2025 for the treatment of uncomplicated urogenital gonorrhea caused by gonorrhea in adults and pediatric patients that are at least 12 years of age and weighing at least 45 kilograms. Now it is given as 3,000 milligrams, so that's actually 4 tablets as 2 doses separated by 12 hours. It was approved based on one study that was an open label, non-inferiority randomized controlled trial that we'll actually look at the next slide. So the study was the EAGLE-1 study, and it looked at gepotidacin, again, given as those 2 doses versus ceftriaxone 500 milligrams IM and azithromycin 1 gram orally as 1 dose. Patients included were 12 years of age and older, 45 kilograms, and they had either suspected uncomplicated gonorrhea or a positive lab test for gonorrhea, or both. The primary outcome was microbiological cure, and gepotidacin was found to be non-inferior to ceftriaxone azithromycin. A couple notes about the study. It was predominantly men around 33 years of age. Not a lot of information on the younger patients, and only about 14% of the patients were from the US, which we know resistance patterns do vary, so that might decrease the external validity a bit as well. Moving on then to our new drug. So zoliflodacin is indicated for the treatment, as I mentioned before, of gonorrhea in those patients at least 12 and weighing at least 35 pounds. It works by being a spiropyrimidine strione bacterial type 2 topoisomerase inhibitor. And it's actually given as a suspension mixed with water, and it must be given within 15 minutes of reconstitution. And so the one dose is given as 3 grams in adults as well as pediatric patients, but those patients weighing 35 to 50 kilograms should take it on an empty stomach. Those weighing over 50 kilograms should take it with food, as food does increase the bioavailability of it. And then, of course, mixing it with other liquids or other foods is not recommended. Now we can look briefly at the study that was used for approval. It was just one study. It too was a non-inferiority open label phase 3 randomized controlled trial in which 621 patients were randomized to zoliflodacin 3 grams orally given as a single dose, compared to 309 patients given ceftriaxone 500 milligrams IM plus azithromycin 1 gram orally. These patients were around 30 years as well. They did have a small percentage. They're representative of those patients younger than 18 years, in which 2% were younger than 18. Predominantly male, predominantly African American, and 22% were HIV positive, with 17% of the study sites being from the US. Inclusion criteria, either symptomatic or confirmed, or actually had to be symptomatic and confirmed gonorrhea infection, or unprotected sex with a partner with confirmed gonorrhea within the previous 14 days, excluding those individuals that had prior antibiotic use that could have activity against gonorrhea, as well as those being pregnant or breastfeeding. So the primary outcome was the proportion of patients with microbiological cure on day 6 in the ITT population, and zoliflodacin was non-inferior to ceftriaxone azithromycin. A few limitations of this study. Again, it was open label, so providers and patients were not blinded. However, there was a use of the objective primary outcome, so that does help to minimize that bias, but could kind of come into play a little bit more when you look at adverse events, since it was open label. Most of the patients were male from areas of high prevalence of gonorrhea infections, which might reduce external validity to other populations, as well as only 17% were from the US, knowing that resistance patterns do vary from different countries and different regions. And there is insufficient evidence for the use beyond of just that single dose of zoliflodacin. And then we know now that current guidelines don't recommend the combination of ceftriaxone and azithromycin because there's such a high rate of azithromycin resistance. However, that was the first-line treatment option at the initiation of the trial, but again, is no longer recommended. A couple safety things to consider with zoliflodacin. The most common adverse events were headaches, neutropenia, leukopenia, dizziness, nausea, and diarrhea. There is a potential for embryo fetal toxicity. So those males with female partners should make sure that contraception is used for at least 3 months following treatment. Zoliflodacin has also been associated with potential to cause testicular toxicity and impair male fertility based on animal studies. And then it does use the CYP3A4 enzyme system for metabolism. And so plasma concentrations might be reduced when zoliflodacin is used with other moderate to strong CYP3A4 inducers. So that concomitant use is not recommended. And then again, zoliflodacin has not been studied beyond that single use, and patients were only followed 30 days. So we don't have any long-term safety data to guide treatment at this time. So the recommendations are no changes to the PDL based on a review of the evidence for this class. And the non-preferred antibiotics are subject to just our general non-preferred PA criteria. And recommendation is to maintain zoliflodacin as non-preferred and then evaluate costs in executive session.
Nice job, Kathy. Any questions for Kathy? Any discussions about the recommendations or a motion to approve?
Motion to approve the recommendations.
Thank you, Doug.
Do we have a second?
Second.
Yeah, all those in favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you.
Fantastic. Next, starting on page 114 in the packet, we have the ZKUBO evaluation, and we'll turn it over to Sarah Fletcher.
Thanks, Roger. Yes, the next drug that we're speaking about is ZKUBO. If you go to the next slide, it is one of our orphan drug evaluations for a medication that is on the high-cost drug carve-out. It's used for pediatric patients with Menkes disease. And the estimated wholesale acquisition cost for this medication is about $700,000 with once daily dosing, or double that for twice daily dosing. The dose is 1.45 milligrams, and it comes as a 2.9 milligram vial, but based on the package insert and my communication with the company, it is single use only, and so you have to waste the rest of the vial for those getting twice daily dosing. If you can go to the next slide. Menkes disease itself is a severe X-linked disorder associated with severe copper deficiency due to inadequate intestinal uptake. And that's caused by a gene mutation in the ATP7A gene, which affects enterocytes as well as the blood-brain barrier. And also patients with this can have abnormalities in their movement of copper into different organs, and so they can actually get toxicity in some of the other organs like the kidneys. It's a progressive disease that usually presents with neurologic symptoms such as developmental delay and epilepsy. It usually presents within weeks to months of life, and classical Menkes can be fatal within the first 6 months to 3 years of life. There is an intermediate form, but it's difficult to differentiate other than how the patient responds and does over time. And then there's a much less severe, much less frequent version of this, which is called occipital horn syndrome. Patients with this can have radiographic occipital horns, and it usually doesn't present until age 5 to 10 of birth. It's quite rare, as you can see, up to 250,000 per live male birth. And in identification of this, serum copper and ceruloplasmin, which is a copper transport protein, they're generally low in patients with Menkes disease, but healthy newborns can also have low levels of these, which makes it difficult alone in the diagnosis until a patient becomes symptomatic, or unless there's some kind of other advanced notice, such as genetic testing of the parents to know that this might be possible. We go to the next slide. As far as ZKUBO, it is approved as a bioavailable copper replacement as a sub-Q injection to bypass this intestinal absorption that's deficient observed in Menkes disease. And it's approved for those who are pediatric with Menkes disease, but not for occipital horn syndrome. We go to the next slide for the studies. The approval of this was based off of 2 pooled studies. One was a phase 1/2 trial, one was phase 3. They were both open label. The comparators used were historic controls. They were from roughly the same medical era. They're not from 50 years ago, but they are historic controls. And then the efficacy was broken into an early treatment group, which was those who were treated within 4 weeks of birth, and a late treatment group for those who were treated first after 4 weeks of birth. And then there's a larger safety population because both of these trials underwent several protocol amendments for inclusion criteria and endpoints and whatnot over time. And so patients who were included in the final efficacy analysis may have met the safety, but some of the patients in the safety analysis may not have been included in the final efficacy analysis. Demographically, it was mostly male, which makes sense for an X-linked disorder, mostly white patients. Most of them were also had premature birth, and that was a little bit higher in the historic control group. The inclusion criteria for this efficacy analysis were those who did have a severe pathologic variant of this ATP7A gene, and I've listed the specific mutations that they included in that slide. And then the exclusion criteria were Wilson's disease, which is another copper transport disorder condition, or compromised gastrointestinal absorption due to other causes. The median exposure to this drug during the study was 24 months, but it did range to about up to 3 years. Go to the next slide. Here you can see the efficacy, and this is something we actually don't see often with the high-cost drug carve-out. They use survival as the efficacy analysis. It wasn't copper levels. And so you can see on the primary analysis was the early treatment group, those who were treated within 4 weeks. At the end of the treatment, 52% of them were still alive versus the historic control of about 12%. And then the Kaplan-Meier estimate on survival for a number of months was significantly higher in that treated group of 177 months versus 17. And then the secondary outcome were the same indicators, but just for the late treatment group, those who started treatment after 4 weeks of age. But so you can see a pretty significant difference in overall survival between these two groups. Now, if you go to the next slide, obviously these trials had some limitations. They were single-arm studies. They had a number of protocol amendments that I mentioned to add the historic control, change in the inclusion criteria from things like copper level to the genetic testing. And for such a rare condition, there is a small sample size. There were also some issues with historic controls as far as the onset of symptoms, but the survival data was considered well verified. And then there was some significant attrition over time, and quite a large percentage of it was considered other. So it wasn't mortality, it wasn't drugs, adverse events, and that wasn't described because this hasn't been fully published yet. Now, if you move to the next slide. Discontinuations due to adverse events were 22% in the early treatment group and 31% in the late treatment group. Those are usually due to cardiac adverse events. And then a number of respiratory, thoracic, and mediastinal events were also considered part of that attrition or part of those adverse events. And then overall, pneumonia, viral infections, respiratory failure, seizures, those were some of the more common adverse events that were reported. But again, remember, there was no placebo group for comparison in the clinical safety. Now, if you'll move to the next slide. As far as safety signals, this is part of the package insert. Because of the mechanism of how Menkes disease affects the body, there is a risk of having copper accumulation in other organs, such as the kidneys, liver, or in the bone marrow. And so it's anticipated that this supplemental copper could increase and cause accumulation in some other organs. And the risk can be higher in those who are younger because of the immaturity of their hepatic and their renal systems. Right now, they don't recommend dose adjustment just based on copper or ceruloplasmin levels, but if there is toxicity, there is a recommendation to potentially adjust. And that'll be more important when we look at the PA criteria. The FDA has recommended a post-marketing study to better understand how this drug should be dosed, though. And if you move to the next slide, we can go over the PA criteria. As I mentioned before, it is part of the high-cost drug carve-out. It was added in May, and we do allow authorization for up to 12 months. You go to the next slide. Right now, we are looking for the ICD-10 code, which this one is an umbrella code. It's not specific for Menkes disease. And so we have some additional questions on, like question 3 is the FDA-approved age and indication. Question 4 and question 5 were to rule out those who have occipital horn disease. Usually classic Menkes is fatal by age 3. Occipital horn often doesn't present until age 5. So if you have a patient who's under 3 years old or a patient who's older than that but has been getting treatment, it's unlikely to be occipital horn disease. But if it's older than that and the patient is being treated for the first time, it's worth asking if that has been ruled out. Question 6 is for a specialist. Question 7 is for the baseline lab work that is recommended in the package insert. Move to the next page. Is the requested dose interval appropriate based on FDA labeling? There are 2 different doses, which I'll show you on the next slide or on the next question. And then question 9 is for the genetic testing specifically because copper levels alone do not diagnose this condition. If it's approved, we would approve enough units for the twice daily dosing up to 1 year of age, or for the once daily dosing if they're over 1 year of age, and we would approve that one for 6 months. Now, because of the early treatment versus late treatment groups, and that was 4 weeks of birth, we thought that timing is actually pretty important for this medication, and so genetic testing can often take weeks. If a patient doesn't have that back yet, we do have the option on question 10 to allow 1 month of treatment while waiting for a genetic testing panel to come back. And then if you go to the next slide, for the renewal criteria, question 1 is monitoring that's in the package insert, because we may be approving for different time periods based off when that first request comes in and someone under 1 year old. We've written out what the specifics are. And again, this lab work is to look for toxicity associated with potential copper accumulation. And then question 2 is to ensure that the dosing is appropriate, and then we can approve it for another 12 months. Next slide. So recommendations are to implement the PA criteria to verify the appropriate diagnosis, monitoring, and dosing. Are there any questions I can answer for the committee?
Good thorough job, Sarah. No questions. Any questions on the proposed PA criteria or a motion to approve?
Motion to approve.
Do we have a second?
Second.
Thanks, Eddie. All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you all.
All right. Next, draw your attention to page 124 in the packet, and we'll turn it back over to Dave Engen.
All right, thank you, Roger. Yeah, next slide, please. So the purpose of this presentation is to evaluate new comparative evidence of benzodiazepines in the treatment of catatonia. Go to just a little background. Catatonia, it's a severe neuropsychiatric disorder. It affects movement, speech, and emotions, and typically causes many autonomic issues. There are at least 3 catatonic signs necessary for diagnosis, including common features such as mutism, posturing, and stupor. Lorazepam generally remains a first-line treatment standard with the use of electroconvulsive therapy for malignant or refractory cases across diverse populations. Yeah, as far as newer comparative evidence, there was a Cochrane review of benzodiazepines for catatonia in people with schizophrenia or other serious mental illnesses. But the review found no clinically important differences between lorazepam and oxazepam for symptomatic improvement of catatonia. We can go to the next slide. In recent years, FDA labeling, it's been updated for benzos regarding box warnings for newborn risks of neonatal withdrawal, sedation, respiratory depression, and of course, strong warnings of abuse, dependence, and risks when combined with opioids, and those warnings have been widely publicized. Yeah, so the Mental Health Clinical Advisory Group supported recommendations to make no changes to the preferred drug list based on the clinical evidence, and to compare costs in executive session. And also recommends updating benzodiazepine PA criteria. That's to align with the current evidence for the treatment of catatonia and to minimize therapy interruptions for treatment of patients with conditions previously approved for long-term use. So if we could look a little more closely at the PA criteria. Currently, prior authorization is not required for short-term use of benzos, so less than or equal to 4 weeks. But PA is required for treatment durations that exceed 30 days of use over the previous 120 days to help prevent inappropriate long-term benzo utilization. Authorization for the longer-term benzo use depends on indication and whether specific clinical requirements are met. So let's review some of the changes to the existing PA criteria. if you just back up a little bit, I have here that we extend the renewal period for up to 2 years for certain conditions that aren't expected to improve or have limited options, but we'll look at those in a minute. Yeah, we can go ahead and on the next slide. We modified question 4 in the approval criteria, the initial criteria, and called out some key diagnoses for things like seizure, catatonia, and short-term management of alcohol withdrawal. You can see the respective initial approval windows of 12, 6, and 1 month, respectively. Then the other change was in question number 15. We added a risk-benefit assessment question, and prior to this, we asked for this in the renewal, so we're bumping that up. If we look on the next slide, in the renewal criteria, you see we extended the potential approval window for second-time renewals of long-term therapy when the prescribers note that symptomatic benefits continue to outweigh the risks. Yeah, so those are the main highlights. Didn't know if you had any questions. I don't believe we have public comment. So,
No, correct. No public comment. And again, this was reviewed by the Mental Health Clinical Advisory Group for their input and approval.
correct. Yeah, so I guess we can keep those recommendations back up and we can allow you to vote on that.
Yeah, I think it's great. I like that the renewal windows are longer. Not everyone who experiences catatonia is, going to have recurrence or need to be on maintenance therapy. But the more episodes you have, the more likely you are to have more of them. So 30 to 60% of people who experience catatonia will have multiple episodes. So I think it's definitely good to have those longer renewal windows. So I think it's great.
Appreciate that comment, Russ. Thank you.
Any other comments or questions? Anyone compelled to move to approve?
I will move to approve.
Thank you, Russ.
Second.
Thank you, Doug. Stacy, you're on mute.
Sorry about that. I could not find my unmute. All
No
those in
worries.
favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you all.
All right. We're cruising. We're up to page 142 in the packet of materials, and we'll turn it over to Deanna Moretz.
Thanks, Roger. This is a new drug evaluation for a drug called Cardamyst or etripamil nasal spray. Excuse me, if we can go to the next slide. So the purpose of this is to evaluate the safety and efficacy of this new therapy, which is approved by the FDA for outpatient conversion of PSVT episodes to normal sinus rhythm in adults. If you recall, the initial approach to treatment of PSVT is generally non-drug-based, using vagal maneuvers, with escalation to IV drugs or electrical cardioversion in the absence of early correction. So adenosine is the IV drug of choice, as the electrophysiological influences are mediated through the cardiac adenosine receptors. IV calcium channel blockers such as verapamil or diltiazem, or beta blockers such as esmolol or metoprolol are also recommended if the SVT is unresponsive to adenosine or vagal maneuvers, particularly in patients that have frequent atrial or ventricular premature beats. And then catheter ablation is also used extensively for most varieties of SVT, and patient-reported outcomes have reported that patients have significant improvement in quality of life following ablation. So most of the therapies we have right now are available as IV, and they're generally administered in the emergency room or inpatient setting. So this is the first drug that's been approved for outpatient use. So if we could go to the next slide. So the mechanism of action is an analog of verapamil, which is a calcium channel blocker. And as I mentioned, the FDA-approved indication is conversion of PSVT episodes to normal sinus rhythm in adults. The initial dose is 70 milligram in each nostril. And if the symptoms have persisted after 10 minutes, they can repeat the 70 milligram doses, the 2 nasal sprays. The manufacturer recommends no more than 2 of those 70 milligram doses in a 24-hour period. Next slide, please. So the comparative evidence table is on page 147. This table is just adapted from that. So the etripamil was studied in a 3-part multi-center randomized controlled trial. So the first part, all the patients self-administered etripamil at home, and they documented each episode via ambulatory cardiac monitoring that was placed on the chest either by the participant or the caregiver and recorded at least 5 hours of the electrocardiogram. In part 1 of the study, there was about 200 patients that received the drug, and they could use it to treat an episode of PSVT until they had the 150th positively adjudicated episode. And then after during that phase, patients were randomized to etripamil or placebo in a 2-to-1 ratio. So that was a phase 2 dose ranging safety and efficacy analysis. Then part 2 of this study was the phase 3 randomized control trial, which was also referred to as the RAPID study. And that included adults that had a documented history of PSVT that typically lasted 20 minutes or longer, who did not participate in, who didn't get the study drug in part 1. So before patients were randomized, they had to undergo a test dose to make sure that they could tolerate the etripamil. And so they got 70 milligrams followed by a second 70 milligram dose 10 minutes later, just to evaluate their tolerability and to train the participants on the study procedures. There was 9 patients that didn't tolerate the test dose. So they had recruited about 700 patients. After all was said and done, after the test dosing, 692 patients were randomized 1-to-1, either to the nasal spray or placebo. So of those 692, 184 of those patients actually had a confirmed PSVT episode during the 24-month trial that the trial was conducted, and so they were included in the intention to treat population. So the demographics for this were mostly female, 71% female, mostly white. The mean age was around 51 years of age for the etripamil group and around 57 for the placebo group. And about half of them were already taking an oral beta blocker or calcium channel blocker at home. So the major inclusion criteria basically was adults with PSVT and a history of sustained PSVT episodes that successfully tolerated the test dosing before they were randomized. So the patients were sent home and they were instructed if they had a PSVT episode to take the first dose, and then if they still had symptoms to repeat that. And then there was an independent committee of about 4 to 6 cardiac electrophysiologists that were masked to the study assignments, and they examined all the data from the 5-hour EKG cardiac assessments, and then they adjudicated the conversion of a confirmed PSVT episode to normal sinus rhythm. So when they looked at that, you can see that more patients in the etripamil group converted to normal sinus rhythm within 30 minutes of drug dosing compared to placebo, which was about 31%. About 60% of patients who got 1 dose required a second dose for the persistent symptoms, And about 79 or almost 80% of patients who received placebo required a second dose to alleviate the PSVT, which is not surprising. Of note, about a quarter of the patients required additional medical intervention after they were randomized, and those patients generally received adenosine, compared with 15% of the patients that got the etripamil. So 25% of patients that received placebo required extra treatment versus 15%. 21% of the placebo-treated patients required an emergency department visit after randomized treatment, compared with 14% of the etripamil-treated patients. And then after they completed this phase 2 part of the trial, they could be enrolled in an open label part 3 for continuing evaluation of the safety of this drug. So if we go to the next slide, some of the limitations were the FDA commented that it's unclear if the success of the primary endpoint was evaluated in the appropriate intention to treat population. The manufacturer specified the efficacy population as the intention to treat, where the FDA considered the modified intention to treat population probably more appropriate. In the modified intention to treat population, there was a little bit less robust response to the PSVT episodes. So about 50% that got the active drug compared to sinus rhythm versus 22% of the placebo-treated patients. So that's why the FDA figured the modified intention to treat population might be more appropriate to evaluate, even though both results were statistically significant. The other thing is the manufacturer said that they only looked at subjects in which confirmed PSVT was counted. There was about 25% of patients who actually did not have a PSVT event, but they used the drug because they thought they had a PSVT event. We go to the next slide. The adverse events that were reported were mostly nasal related, which is not surprising because this is a nasal spray. So nasal discomfort, nasal congestion, runny nose, throat irritation, or bloody nose were the most frequently reported events. Now this is the results from all 3 phases of the trial, not just the phase 2 portion. So there are some contraindications with this drug, and most of those are related to people that have some sort of cardiac dysfunction, either heart failure, or if they have arrhythmia, or if they have an AV block. Those are contraindicated. The other thing, because this is a calcium channel blocker, it can cause dizziness or syncope, so patients are recommended to take this drug or to administer it in a sitting position. So the recommendations for this are to maintain etripamil as non-preferred on the PDL, and then to implement PA criteria to ensure appropriate utilization of the nasal spray. The PA criteria begin on page 151. I will comment, one bottle of this drug costs about $2,000, and it has the 270 milligram doses in it. I think the manufacturer may have calculated the dose for this to consider it cheaper than an ER visit. So our PA criteria are the standard criteria. We're ensuring that this drug is appropriately used according to the FDA indication. We would approve the request for up to 12 months. And we ask the standard, what's the diagnosis, and is it an FDA-approved indication? And then we want to make sure there's documentation of having PSVT being documented by electrocardiogram, requiring emergency care in the last 12 months. If that's the case, then we would go on to making sure it's prescribed by a cardiologist. And then question 5 just outlines all the contraindications that are in the prescribing information. And then we added a question about whether catheter ablation is not suitable for this patient. Excuse me. So if we go to the next slide, I think it's just a summary of the recommendations. which are to maintain etripamil as non-preferred and to implement PA criteria. Are there any questions from the P&T committee?
Yes, could you go back to the former slide?
To the last page for the PA criteria?
There we go. So number 6, I'm thinking that this may actually be something that that a cardiologist would prescribe while the patient is being considered for catheter ablation. And I guess, I see, not appropriate well, it may be appropriate. It's just they have to actually schedule them. They've got to, get them to, yeah. How are
Would you
you?
want to revise that to maybe put do they attest that it's pending? Something along those lines?
So Doug, why would you do that? I mean, I guess I'm trying to figure out where you're coming from on this. So if they are you saying like they've got an ablation scheduled or they're a candidate, but the current therapies are not controlling their symptoms, and so we would want to give them this to tide them over to the ablation?
Agreed.
Okay, all right.
Also, it may take a while for the catheter ablation is suitable, but the patient isn't amenable yet. I mean, I just can't imagine a cardiologist having a patient with this condition
Yeah.
and not consider, and in fact, advising ablation.
Right.
So I mean, it's like knee jerk. So that is the intervention for recurrent
Right.
PST, VT. So so it's almost, I guess it may be redundant. It may not be necessary, I guess, is what I'm wondering.
So you're recommending we just eliminate question 6?
Yeah, I think you're going to have to go to, it may end up, if it's prescribed in consultation with a cardiologist, then I see. So a PCP might be prescribing this, and they're not on top of, that's the curb for them continuing to prescribe it for years.
Right, and because we've required that a specialist prescribe it, I think that sets it up that they would be considering ablation.
Yeah. I don't know. I think you may end up it's more work than you need.
I'm on board with that.
Just dropping it.
Just drop the question. Yeah, because I agree. I mean, there's not going to be, I can't imagine a scenario where it's either prescribed by or in consultation with a cardiologist where ablation isn't the plan, right?
The preferred plan.
The preferred plan,
and,
yeah.
Trying to get a patient to accept it and follow through. And also, there are patients that have already received ablation that have recurrence, unfortunately.
Right. Yeah.
And that's it's only about, I don't know what the percentage, but I would guess it's 70% effective, ablations. So
you're making a motion to accept the PA criteria as amended by removing question 6?
just remove question 6.
That works. Do we have a second for that motion?
Second.
All right. All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right. Thank you.
Good discussion. Thanks for that input and modification. We're a little ahead of schedule, but next up on the agenda is a break. So I'm going to start my timer and give you all a 15-minute break. So let me share a window. And are you able to see that?
Yep.
Okay. Fantastic. We'll see you back in 15 minutes.
Okay.
All right. We are finishing up the break. Hope that was sufficient time for everybody. We still have a couple more topics to get to before we go off into executive session. Again, the pricing is probably going to take a little bit longer this afternoon just because of some of the new evaluations we need to do with that hot population. Nonetheless, we're going to continue on. So if you're following along in the packet of materials, bring your attention to page 153. And Deanna, we'll turn it back over to you.
Thanks, Roger. I did get some water during the break. I think my allergies are kicking in, so I apologize for the coughing fits I had in the last presentation. Hopefully, it will go a little smoother this time. So we're going to be talking about spinal muscular atrophy, and there's a new drug that's been approved for treatment of this condition. If we could go to the next slide. The first time we talked about SMA was way back in 2017 when we were still meeting in person. And those of you that were on the committee then may recall we had a lot of public comment the first time we talked about Spinraza. We had patients that came. There's been a lot of research directed towards treatments for this rare disease, which is a rare autosomal recessive and progressive neuromuscular disorder that's caused by mutations in the SNM1 gene. And so that reduces the functional protein that is important for the muscles to work appropriately. So we're going to look at any new evidence for the management of SMA and then talk about this new gene therapy, Itvisma, or onisenogene abiparvovec, which is a new intrathecal formulation of gene therapy. So if we go to the next slide, this is just a summary of the 4 medicines that have been approved to treat SMA. The first was Spinraza, as I mentioned, way back in 2017. That's an intrathecal injection that has to be given once the patient's loaded up. It's given once every 4 months. We'll talk about it. There's a new high-dose version of Spinraza that was recently FDA approved, and it's indicated for all patients with SMA. Then Zolgensma is the intravenous infusion gene therapy that's given one time, and that's approved for patients that are less than 2 years of age that have the mutations in the SNMN1 gene. And then, like I mentioned, we're going to be talking about Itvisma, which is the new intrathecal injection, which is approved for children 2 years in age and older that have the confirmed mutation in the SMN1 gene. And then finally, we have Risdiplam, which is an oral tablet or suspension. The tablets were recently FDA approved. That's taken once every day by mouth, and that's approved for all SMA patients. So if we could go to the next slide. No comparative studies have been done on these disease-modifying treatments because mostly the populations are very heterogeneous, and they look at different outcomes, which makes it difficult to interpret the results on a comparative basis. There's no recent high-quality systematic reviews, but there were 3 high-quality guidelines that have recently been published. So Canada's Drug Agency came out with some recommendations. The first one that they looked at in 2025 was the evidence for the efficacy and safety of using nusinersen and risdiplam for adults with SMA. And based on the available evidence, they do not recommend reimbursing starting nusinersen in patients patients with late onset SMA or more slowly progressive forms in patients that are 18 years of older for nusinersen or 25 years and older for risdiplam. No changes have been made to the 2021 guidance that Canada's Drug Agency issued for using risdiplam in patients with SMA that are aged 2 months and older that have genetic documentation of the SMA diagnosis. And then just as a reminder, the CDA guidance from 2021 recommends that Zolgensma be used in SMA patients that have genetic documentation of the condition if they're 180 days or younger. Next slide is the NICE guidance. So NICE updated their guidance for Zolgensma in April of 2023, and they recommend it as an option for treating SMA in patients that have the biallelic mutation in the SMN1 gene, and if they have a clinical diagnosis. Now, the NICE guidance is a little bit different than our FDA approval. Basically, the FDA just approves Zolgensma in all children that are under 2. NICE recommends that it be started in children that are 6 months of age or younger, or if they're age 7 to 12 months, if it's agreed on by a multidisciplinary team. The exclusions of a patient having a tracheostomy or permanent ventilation are very similar to the FDA labeling for Zolgensma in the United States, and that's also included in our PA criteria. And then NICE also updated guidance for risdiplam in December 2023, and they recommend it for all types of SMA, types 1, 2, or 3, or pre-somatic SMA if they have 1 to 4 copies of the gene. We could go to the next slide. I mentioned there's some new formulations. So in February of 2025, the FDA approved a new tablet formulation of risdiplam based on pharmacokinetic studies comparing it to the suspension. And the oral tablets are indicated for patients who are 2 years of age and older who weigh 20 kilos or more. And then earlier this year, the FDA approved a higher dosing regimen for nusinersen. So the high dose regimen starts with a 50 milligram loading dose every 2 weeks for 2 doses, followed by a 28 milligram maintenance dose every 4 months, starting 4 months after the last loading dose. I just put the previously approved low dose regimen there for context. So it's 12 milligrams for 3 doses, followed by the fourth 12 milligram dose, and then it's a 12 milligram maintenance dose once every 4 months. So the new nusinersen higher dose is available in 50 milligram and 28 milligram vials. And then there are FDA safety alerts listed on page 161 for nusinersen, and we've incorporated some of those safety alerts into our PA revisions, which we'll get to in a little bit. We go to the next slide. So let's talk about the new drug, or Itvisma, and it's a AAV vector-based gene therapy. It's approved as a one-time intrathecal injection, and its FDA-approved indication is for SMA in adults and pediatric patients that are 2 years of age and older with a confirmed mutation. Unlike Zolgensma, which is weight-based dosing, this intrathecal injection is administered as a fixed dose independent of patient weight, and it's a lower intrathecal dose than what's given intravenously. We could go to the next slide. So the STEER trial was the confirmatory trial that they FDA based their approval on. Patients that were excluded from this had cardiomyopathy, hepatic dysfunction, kidney disorder, or severe respiratory compromise. If they had AAV9 antibody titers greater than 1 to 50, if they had an active infection, or if they were on ventilation in the last 30 days. So they use this dosing of I just abbreviated the drug as OAV because it wouldn't all fit on the slide, but they gave this 1.2 times 10 to the 14th vector genomes times 1 doses versus a sham intrathecal injection times 1 dose. They recruited 126 patients. The average age for these patients was almost 6 years old. It's about half male, half female. 60% of them were Asian. several of the study sites were in Thailand, Vietnam, and Singapore. So I think that's why we saw a broader representation of Asian populations. And almost all of the patients had 3 copies of the SMN2 gene. The major inclusion criteria were they had to be 2 to 17 years of age, and they had to be treatment naive to SMA treatment and able to sit but not independently walk. The trial was conducted over 52 weeks, and the primary efficacy point was change from baseline in the Hammersmith Functional Motor Scale Expanded Score. The different motor scores are described on page 157 in Table 2. But basically, the published minimum clinically important difference for the HFMSE score is 3 points. However, in this study, the investigators used an MSCID of greater than 1.5 points based on a 2024 study of patients with SMA types 2 and 3. So in the literature, MCID values range from 1.5 to 4, depending on the statistical method that they use to evaluate the clinical significance. And the MCID values may be different depending on what symptoms are improving versus which ones are worsening. So in this study, the investigators found the optimal cutoff points to be 1.5 for improvement and negative 3.2 for deterioration. So based on that, they did find statistically significant improvement with the intrathecal administration of onasemnogene versus the ones that received the sham injection. If we could go to the next slide. So the trial limitations, there was a broad inclusion of all patients regardless of what their baseline motor skill assessment was, and wide age range in the eligibility criteria. At the time of recruitment, many of the younger patients that were eligible had already received the IV gene therapy. So that meant the trial population on an average was older than those that were studied in previous trials. Most of the patients in this study were 6 years of age or older. The other thing is it was just a 12-month period of observation, so that might be not enough time to evaluate changes in motor function, the full benefit that they might achieve, or any delayed adverse events that they might experience from the gene therapy. The most frequently reported adverse events reported with intrathecal therapy were upper respiratory infections, pyrexia, and upper GI symptoms. There is a black box warning for both of these gene therapies, the Zolgensma and the Itvisma, for serious hepatic injury, and monitoring liver function is recommended. And the label says that patients with pre-existing hepatic impairment may be at higher risk for hepatic injury. So the recommendations are on the next slide, and we're not recommending any PDL changes at this point based on the available evidence. But we did revise the PA criteria to include this intrathecal gene therapy, and we will look at drug costs in exec session. So the PA criteria start on page 172 if you're following along in the packet. What we did on this first page was just add the Itvisma, or the intrathecal gene therapy, and we didn't change the length of authorization for the gene therapy. It's just once in a lifetime. We go to the next slide. So the only thing we did on this PA criteria on this page is to add the onasemnogene intrathecal version. And then in question 3, we added a request for the reviewers to document the results of the genetic testing. That's in line with what we've been doing with a lot of the high-cost drugs that are generally approved for genetically acquired or genetically inherited diseases, is to ask for documentation of the genetic testing. If we could go to the next slide. The changes on this were we decided it would be good to put a time frame for when the motor assessment, the baseline motor assessments were evaluated. So we added evaluation within the past 6 months. And then question 7 is a question that we've been adding to a lot of our high-cost drug therapies is, has the provider documented goals of therapy for this treatment? And I think this is based on a lot of discussion that we've had with the P&T committee about how do we decide if this very high expensive therapy is working and if it's appropriate to continue treatment with it. And then for question 9, we added the intrathecal gene therapy. And then question 10, we just modified that to be specific. The only 2 drugs that are continued lifelong are the nusinersen and risdiplam. The gene therapies are just once in a lifetime. If we could go to the next slide. So question 15 is an addition of the safety monitoring that was recommended by the FDA, including platelet counts and then urinary protein concentrations. And then in question 10, we just added the age ranges for the 2 different gene therapies. Zolgensma is for less than 2 years of age, and Itvisma is for over 2 years of age. And then on the next slide is the renewal criteria. And so we modified this quite a bit in terms of if they've gotten the gene therapy, there's no evidence that patients should get gene therapy and then start on nusinersen or risdiplam or vice versa. So if they've gotten gene therapy, they should not be continuing these therapies. And then question 3, we modified before we had all the motor function assessments listed in there, and we decided to align question 3 with question 7. So is the patient meeting the goals of therapy as outlined in the initial approval? And with that, I will open it up to the P&T committee if they have any questions about how we modified the PA criteria, if there's any questions about the evidence for the new gene therapy.
I might have 2 things. Number 8, on the approval criteria with the PFTs, I think often these kids are so small. Is that maybe from like a clinical trial inclusion criteria or?
That is from a previous P&T member, and I'm glad you asked that because we were having an internal question ourselves. We were like, where did that come from? And Dave remembered that one of our previous P&T members requested that we add that, and I think it had to do with the fact that if they're on a ventilator, that's one of the exclusions for getting this treatment. So I would leave it up to the committee if they think that's still a good question to ask. It's not in any of the clinical trials. Like I said, it was just a recommendation from one of our previous members that we add that.
It does ring a bell. And then I guess related to the ventilator piece, which number is that? I was kind of torn about the like 16 hours on event because I think that's probably also clinical trial inclusion criteria. And like most of these kids aren't, at the time of gene therapy going to be that progressed, but I was torn. There was like observational data from the UAE, like in sort of pretty progressed kids getting gene therapy that they perhaps conferred some benefit. I don't feel informed enough to have a strong opinion on this, but it does feel like maybe a little precarious to be making a judgment there.
That definition was based on what they used in the Spinraza trials, not the gene therapy. So that's where that came from. But if you think we should modify it, we can.
I reluctantly have an inclination to modify it. I'm curious if anybody else has a feeling. Again, I think it's pretty unlikely that like a kid with SMA that's going to be a candidate for the gene therapy would be that ventilator dependent. But there may be a cohort of kids that could be there. And I think like if other folks don't have a strong opinion, like would it even be worth just like soliciting input from outside expert opinion? I just,
Yeah, I don't
it feels
feel like I have a strong opinion, but I also don't have enough of an experience to understand like what kinds of folks are actually meeting that criteria and who aren't. It just feels like a pretty difficult question to answer on our own.
Yeah, I agree. And I remember the original conversation. And I agree with both points of view, but I wouldn't know what to suggest for modification. So I think if we don't want to leave it as is, then I think we need to get some clarification and bring it back in a future meeting. Like, unless Pat, you feel comfortable suggesting modifications, yeah, I wouldn't even know how to vote on that, right? Because I don't have enough experience, and I do remember that the initial conversation around this, we did get some input from like an expert, I think, that was either at the meeting or we had reached out and decided to leave it in. And so that's why I'm kind of like, doesn't mean we can't change it, but there was input from an expert that led us to leave it in initially. So if we're going to change it, I think we should get an expert opinion to change it.
Great memory, Stacy. And Sarah, have we denied any of the gene therapies? Can you recall? I did not look at the approval denials. I know we have one patient that's getting Spinraza. That showed up on our DUE materials that we were looking at today, but I don't know if we have denied Zolgensma because of them being ventilator dependent.
Yeah, I don't recall that we have. We can go look, but I too remember the conversation because we were debating whether or not using a ventilator at all meant they're vent dependent, and then there was a person that was using it for assistance. I think that's why we added that note as well, and then said if they were using it for the 16 hours, okay, that is more kind of definitive that they're event dependent. We do have 2 people providing public comment. They may be able to speak to this, then we could do some more research and bring it back if necessary. So if we're on the fence about leaving it or making any amendments right now, just want to throw that out there for consideration.
That makes sense. Why don't we hear the public comment and then we can decide what to do next?
Okay. Let me get my handy dandy timer up. And the first up, we have Robert Knopp from Novartis. Robert, are you able to unmute your line?
Yes. Can you hear me?
I can hear you loud and clear, and the floor is yours.
Actually, I don't really have anything to say except for I'm an MSL for Novartis Gene Therapies, and I'd be more than happy to answer any questions. So I was here to answer questions.
Okay, I appreciate that. Any questions for Robert with him showing up? And I do appreciate your, respecting the committee's time.
So in the clinical trials that led to approval of the gene therapy that you represent, were there any inclusion criteria in those studies related to ventilator dependency?
Yeah, for Zolgensma, both of them, Zolgensma was the 16 hours as mentioned, and then also the Idvism is the same way. Both of those both trials had that requirement. Now, to comment about sort of intermittent ventilation, it's not uncommon for these patients to, for example, have to go in for surgery, whether it be spinal fusions or have some other infections, and then they have to be on ventilators post-surgery or whatever for extended period of time because of their clinical status. So they will require ventilation longer than a quote-unquote non-affected patient, but eventually they should be able to titrate that off. So there is some variability in ventilation support in these patient population, but for the most part, the ventilation dependent was usually 16 hours for a certain period of time for which that is measured.
All right, so it sounds like our criteria is comporting with that. So
yeah,
appreciate that.
No problem.
Okay, we also have Linda Finch from Biogen. Are you able to unmute your line, Linda?
I am. Can you hear me?
Hear you loud and clear. And you have the floor for up to 3 minutes.
Okay, thank you. Good afternoon. My name is Linda Finch. I'm a medical account director for Biogen, manufacturer of nusinersen or Spinraza. As was mentioned on March 30th, the FDA approved a new higher dose regimen of Spinraza. And I understand you're not specifically evaluating the new high dose today, but would like to share some information for your future consideration. Spinraza has shown clinically meaningful and sustained efficacy across the SMA spectrum with a well-established safety profile of the lower dose 12 milligram regimen with more than 10 years of clinical trial and real-world experience in over 14,000 individuals. And we've shown clinically meaningful efficacy, but there still has been remaining unmet need in SMA. And recognizing that unmet need, we evaluated a higher dose regimen in the DEVOTE study, and that included participants that were naive to SMA treatment and participants who were previously on Spinraza for at least a year. And these studies included individuals with both infantile onset and later onset SMA of all ages, but not adult onset. So these were mainly types 1 through 3. And these patients are now being followed for up to 5 years in a long-term extension study. So the DEVOTE study met the pre-specified primary endpoint and led to clinical and significant improvements in motor function, survival, and all other outcomes relative to the infantile onset matched sham group. And trends favored the high dose group over the 12 milligram dosing group across nearly all secondary measures of efficacy in the infantile onset group. And in the later onset participants, trends on the Hammersmith Functional Motor Scale Expanded and the Revised Upper Limb Module favored the high dose group over the low dose group, and the matched sham and low dose groups from CHERISH, our previous clinical trial in this patient group. So we saw clinically meaningful improvement in functional outcomes on the Hammersmith and the Revised Upper Limb Module when previously treated participants who'd been on the 12 milligram regimen of Spinraza for a median of 3.9 years were transitioned to the high dose regimen and treated for 1 year. And these improvements would not be expected in patients who've already been on treatment for this length of time. And the improvements were observed across phenotypes, functional status, and age. The most common AEs were pneumonia, respiratory failure, pyrexia, COVID-19, upper respiratory tract infection, procedural pain, and headache. Overall, the high-dose regimen provides clinical benefit with a generally well-tolerated safety profile, and I'm requesting that the high-dose formulation be made available as an option for individuals with SMA. So thanks for your time today. I can weigh in on the question of the ventilation if you like, just to share that we included that as an exclusion criteria in our trial because one of the primary endpoints of the trial was time to permanent ventilation. We have seen in our trials that even patients on permanent ventilation can have improvements in motor function. And so we do recommend removing that restriction for these medications. At least for Spinraza, we have seen that benefit. And your idea to get expert opinion, I think, is an excellent one. So thank you for your time, and I'll take any questions.
Thank you,
I just
Linda.
had a quick
Any
question.
questions? Yeah.
My question, from my reading, there's really no advocating for high or low dose. It's pretty much what the provider wants to do for dosing. Do you have any guidance for which dose should be used?
So we are keeping the lower 12 milligram dose on the market because we want to minimize patient disruption. But the feedback that we have gotten from physicians is the desire to move patients to the higher dose. So that may be occurring over, period of time. There doesn't seem to be, at least from the data we have collected so far, there doesn't seem to be a trade-off in terms of more risk or safety concerns with the higher dose. I don't generally speak to the pricing, but they have priced this for parity pricing. So to eliminate that restriction, a potential access barrier. So there isn't generally a reason to not move somebody to the higher dose with the
That's
efficacy
very
we're
helpful.
seeing.
Thank you.
Appreciate that, Linda. Any other questions? All right, thanks for your input, Linda. So if we can put the recommendations back up. If Sarah searches to bring those up, Deanna, if you want to recap those.
So no PDL changes are recommended based on the evidence that we looked at, and we're going to revise the PA criteria. I would open it up to the P&T committee. I think we have two options. Should we maybe get some input from some experts, perhaps the expert that previously came to P&T regarding questions 5 and 8 and bring it back? Or do you want to leave the PA criteria as listed in the packet?
I think it was Erica Finanger from OHSU that came long
It
ago.
was. Great memory. Yeah.
So I'd maybe propose reaching out to her.
That works for me. So do we need to make a motion then to
So the
not do
proposal
something?
today is to amend where it's redlined. I don't think 8 was being redlined either, was it?
No.
And so what I'm hearing is the recommendation is to update the PA criteria as proposed, but for us as staff to have a takeaway to go engage Dr. Finanger on your question, Pat.
Motion to approve.
All right, do we have a second?
Second.
Great. All right, all those in favor?
Aye.
Aye.
Opposed? Abstain? All right, thank you all.
Good discussion. Thank you. Next, turn your attention to page 178 in the packet posted on our website, and we'll turn it over to Sarah Fletcher.
Roger. Next up on the agenda, we are going to look at some of the newer agents for myasthenia gravis based off of a Drug Effectiveness Review Project Summary, or a DERP summary. If you go to the next slide, these new agents are not a class in and of themselves per se. They're spread across multiple classes right now. Several are in the orphan drug policy. Most of those also have additional indications for things unrelated to myasthenia gravis, and they're held to label based on the drug policy PA. One agent, efgartigimod, is still in the biologic agents for rare diseases class, and it has a drug-specific PA. And then amifampridine, which is for something called LEMS, or Lambert-Eaton myasthenic syndrome. It's a more rare version or more rare condition that is similar to myasthenia gravis, is in a class by itself in the potassium channel blockers. They all currently have PA criteria, basically restricting them to indications, and with efgartigimod and some of the others looking at also safety indications or safety warnings as far as getting vaccinations for certain things that they're at risk for. And then the other, and just as far as looking at this class in the past, we looked at efgartigimod before in April of 2022 and looked at amifampridine for Lambert-Eaton myasthenic syndrome in 2019. The drugs in the orphan drug policy, a few of them were looked at specifically for evidence for their other indications and myasthenia if they had the indications, but then they were all moved to that class because because they had so many different indications, it was difficult to have drug-specific PAs, and they're so rare that we thought that that policy would do a good job of managing utilization. Now, if you go to the next slide, I just want to clarify which medications we're talking about, because myasthenia has first-line treatment with things like pyridostigmine and immunosuppressants, and those have availability, and those aren't the ones that we're looking at today. So today we're looking at amifampridine for LEMS, which is available as an oral agent, and then all of the other drugs that you can see on the left. They do have different indications, as you can see in the middle column. The indications vary based off of what receptor antibody status the patients have. So that AChR, or acetylcholine receptor antibody positive, is the most common antibody that patients with myasthenia have. The MuSK, or anti-muscle specific tyrosine kinase, is the next most common. And then there are a few others that don't have specific indications that patients can have. They do vary on their mechanism of action, and most of them, other than amifampridine, they're all injectable. Most of them are IV. A few of them are sub-Q, but provider administered because of infusion type reactions. And then the last one, zilucoplan, is sub-Q and available daily. So if you move to the next slide. Since this is a DERP report, it'll look a little bit different than how we typically look at and present results, but they looked at almost 900 different records in their literature search and identified 13 different randomized controlled trials. All of them are placebo control, and unfortunately, no head-to-head comparisons between the different agents. I'm going to briefly, if you go over the next slide, do a very high level summation of those 13 trials. And because it is a DERP summary and because we're summarizing someone else's information, I just wanted to kind of give a preface. Generally, they were looking at symptom, function, quality of life as outcomes, and there are multiple different tools used for each of those. Those are described in the DERP summary, and they have different MCIDs. A few of them, one of the quality of life tools doesn't have an MCID. And then they rated the studies as far as risk of bias and certainty of evidence, which is that COE. And if looking at the different studies, if they had a clinically meaningful change in MCID, I did put it in orange to try to make it a little bit more obvious as we go through here. So amifampridine for LIMS, which is its FDA indication, there were 2 studies identified. One was 2 weeks long, one was 4 days long. So very, very small, very high risk of bias. The function measures show statistical improvement, but no difference compared to, no other differences compared to placebo. The quality of life was not assessed, and the adverse events were similar in one study and more common in the placebo patients in the other. Now, if you look at the next, the lower part, amifampridine in myasthenia gravis, which is off-label, was only looked at in one RCT. It was actually a crossover study for 3 weeks, 1 week on, 1 week off, and patients who got the drug on week 1 and week 3 were counted twice, so it was a very high risk of bias design. They did see some small clinically meaningful different increases in the symptom severity score compared to the increases seen in placebo, as well as functional and quality of life. But again, this was a very high risk of bias study with very low certainty of evidence. If you go to the next slide, eculizumab. This medication is available as its brand name, and it has, I think, 2 different biosimilars at this point. It was based off of, the evidence was off of 2 trials, a smaller 14-person study as well as a 126-person study over 26 weeks. 26 weeks is about the longest duration that we will see as we go through these. They did look at 2 different symptom severity scores, and there was a statistically and clinically meaningful decrease in both of those. Functional scores, one of the trials had a clinically meaningful difference. I think it was the bigger one, if I can recall. And then quality of life did have clinically meaningful improvement. Adverse events were similar, and severe adverse events were similar between the studies, but very different between the 2 studies. You'll notice 1% in the smaller study versus 15 to 30% in that larger study. We go to the next slide. We have got efgartigimod, which is available as an IV or as a sub-Q version with hyaluronidase. The hyaluronidase version was approved based off of pharmacokinetic comparison and not any trials in and of itself. It was evaluated using 2 different studies. The second one was larger and 10 weeks long. The symptom severity scale, or symptom severity scores, were using 2 of the different scales were both clinically meaningful, and the functional scores were clinically meaningful. Quality of life did show differences, and those waned over time. And I'll note that all of them waned over time. This one is dosed as once weekly for 4 weeks, and then additional cycles are determined based off of the length of response. Most of the patients did experience an adverse event, but there were no differences between the groups, and there were very few severe adverse events. The next slide, nipocalimab. In the DERP summary, they only used the single phase 2 RCT. I'll note at the bottom there was a phase 3 study that did come out after the DERP summary, and I have a minimal assessment of it. But there was a single RCT of 68 patients with multiple different dosing groups, so there were small numbers in each dosing group. There were no differences in symptom, function, or in quality of life, except with the high dose 30 mg per kg, which is not an FDA-approved dosing interval. There weren't differences in the adverse events. There were few severe adverse events and no differences between the groups. In the phase 3 study, there was a statistically significant difference in the functional scores, so the myasthenia gravis adverse, or ADL, so activity of daily living, and then the total adverse events and severe adverse events were similar in that phase 3 study. Next, we have ravulizumab. The DERP summary included 1 RCT of 175 patients for 26 weeks, so one of the larger and longer durations. There were no clinically meaningful changes, but there were some statistically different or statistically significant changes in symptom and function, but not in quality of life. No differences in adverse events between groups, though quite a few did experience at least 1 adverse event. And then there were severe adverse events in both groups, which is different than some of the other studies we've seen where they didn't have any severe adverse events, but it was longer. If you go to the next one, I'll see if I can get rozanolixizumab. Their evidence was based off of 2 RCTs, a small phase 2 and then a larger phase 3 of 200 patients over 6 weeks. That one did have 2 different dosing groups. There were clinically meaningful differences in symptom and function, but only in the larger phase 3 trial. They didn't look at quality of life, and there were some statistically significant increases in adverse events for the higher dosing group. And the way this drug is approved is it has dosage ranges of less than 50 milligrams or kilograms gets 1 dose, 50 to 100 gets another dose, over 100 kilos gets another dose. So depending on where you are in that dosage range, you might be closer to the 10 milligram per kilogram versus the 7. So that's something to look at when a patient is receiving this. But there were no differences in the severe adverse events between the different groups. And then lastly, zilucoplan for myasthenia gravis. This is the newer agent that is available as a sub-Q daily. It's the most frequent dosing interval of the ones we've reviewed. It was studied using 2 different RCTs, a phase 2 study that was small, and then a larger 174-person phase 3 study. The symptom severity had statistical differences, but it didn't quite meet the NCID threshold. But there were functional or clinically meaningful differences in all of the dosage groups for the functional status. The quality of life results were mixed, and I believe the quality of life assessment they were using did not have a known MCID. Most patients did experience an adverse event, but they were pretty common and similar to placebo, and the differences weren't significant. Now, if you move to the next slide, and I just went over very quickly, high level, 13 different studies. Based off of that, there's really no head-to-head comparative evidence between the agents. All of the evidence was on 1 to 2 RCTs using a placebo. They varied by size, they varied by population. I didn't talk about this a lot, but with the different antibodies, these different trials, some required AChR positivity, some required MuSK, some just reported both of them. And so that varied in all of the different trials, as well as background therapy and failure of previous agents for the standard therapy. The durations ranged. Some of that was because they have different onsets of action. Some of them have very quick onset of action versus others are a little bit longer. The designs were different, and some of them were, the 2 trials were phase 1 or phase 2 and phase 3 rather than 2 phase 3 trials. So the certainty of evidence for all of these outcomes was pretty low to very low, and all of the studies that they reviewed in DERP were moderate to high risk of bias. And so based off of that, there really is insufficient evidence to show superiority or improved safety of one agent over another as far as trying to look if we need to make this a class or not. And I also wanted to note what I said at the beginning, they all vary by route of administration and interval, and so that can make a difference as well in patients that may have more advanced disease, and it may be more difficult for them to come in and receive infusions. So if you go to the next slide, I don't have any clinical changes to the PA criteria. I have a few clerical ones I just wanted to mention. For amifampridine, we have a question about preferred drug status, and it's the only medication in the class right now. And there's only 1 version of it currently. There was previously a second version available, and there's no preferred drug. So we wanted to just remove that question. And then the next question was the drug-specific efgartigimod PA. Myasthenia gravis is funded, and so questions 2 and 3 about funding status are really not necessary. And with the benefit review benefit review plan where funding status is going away in 1127, I wanted to take those questions out. And then in question 10, the dosing for Vyvgart and then Vyvgart Hytrulo, which are IV versus sub-Q, they're different. And so I didn't want to have a dose in there that was only specific to one of the agents. If you go to the next slide, overall, my recommendations are no changes to the preferred drug list or the clinical prior authorization changes based off of the clinical evidence, just those clerical changes that I mentioned. But I do want to look at costs in executive session. Are there any questions I can answer?
Good job, Sarah. We do not have anybody that signed up for public comment. So questions from the committee for Sarah? And if none, we'd entertain a motion.
Motion to approve the recommendations.
Do we have a second?
Second.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thank you.
Okay, great job. So for our last topic of the day, turn your attention to page 193 in the packet, and we'll hand it back off to Deanna.
Thank you, Roger. I'm just trying to take myself off mute here. There we go. So this is our second orphan drug evaluation of the day, and as both the Sarahs mentioned, we've modified how we do the reviews. They're more abbreviated because a lot of times there isn't great evidence for these drugs, unfortunately. So if we go to the next slide. The reason for this is to review the evidence for the safety and efficacy of pegzil-arginase, which was recently FDA approved as therapy for hyperarginemia in people aged 2 years and older that have the arginase enzyme 1 deficiency, which is a urea cycle disorder, and to establish medically appropriate criteria. This is a high-cost drug. The wholesale acquisition cost for each 2 milligram vial is a little over $11,000. The dosing is weight-based. So Sarah helped me with the calculations. If we start at the 0.1 milligram per kilo per week, and we dose it based on plasma arginine levels to a maximum dose of 0.2 milligrams per week. So the price could range from $357,000 per year for a 2-year-old to over $4 million per year for a 70-kilogram adult that's getting the maximum dose. So next slide, please. So this is a rare inherited metabolic disorder of the urea cycle with autosomal recessive transmission. It's mostly due to the deficiency of the arginase 1 enzyme, and it causes progressive neurologic damage. The pathophysiology of this particular condition suggests that the elevated arginine, not elevated ammonia like the other urea cycle disorders, is what causes the development and progression of the clinical manifestations. Preventing symptomatic hyperammonemia, high ammonia, does not prevent progression or long-term outcomes in these patients. So typically, children that are between the ages of 2 and 4 are the ones that begin to show the signs based on neurologic symptoms. And although increased plasma arginine is the disease hallmark, the arginine level may not always be exceedingly high. The diagnosis is confirmed by enzymatic assays in red blood cells or by a genetic analysis. So treatment focuses on dietary protein restrictions, supplementing essential amino acids, symptomatic treatment for spasticity, and maybe using alternative pathways to remove nitrogen waste. The thought is lowering the plasma arginine concentrations to less than 200 millimoles per liter might reduce the neurotoxic effects, including intellectual disability, developmental delay, and seizures. And it also might slow the disease progression. In our OHP population, we have not identified any patients, although OHSU practitioners report that they have 2 patients that have this diagnosis. We could go to the next slide. NICE did issue some guidance for the use of this drug in earlier this year in March 2026, and their review of the evidence showed that using pegzil-arginase plus usual treatment reduced the levels of arginine in the blood compared to placebo plus usual treatment. However, they cautioned that lowering the plasma arginine levels doesn't have a consistent relationship with the disease severity. And evidence suggests that there are improvements in mobility and mental processing, but because the studies were small and short, the evidence is unclear. So we really don't know at this point how large those benefits would be or how long the improvements will last. That said, NICE does recommend pegzil-arginase can be used within its marketing authorization as an option to treat patients that have the arginine 1 deficiency in people 2 years and over. So if we go to the new drug review or the orphan drug review, so it's a recombinant and pegylated human arginase 1 enzyme therapy. So it provides an exogenous source of the enzyme that they do not have enough of. And that reduces the plasma arginine by converting it to urea and ornithine, which then can be excreted. So the FDA approved indication is treatment of hyperarginemia in adults and pediatric patients 2 years of age and older, in conjunction with dietary protein restriction. Just the next slide. These are the motor function assessments that they used in the clinical trial. So they used the 2-minute walk test, which evaluates distance traveled on a flat surface. And in the PEACE trial, 9% change from baseline in distance traveled was considered clinically significant. And then they also used this gross motor function measure, Part E, which includes 24 tasks involving walking, running, and jumping with a score of 0 to 72. The individual scoring is listed there. Lower scores indicate more functional mobility impairment. And so in the PEACE trial, a score change from level 1 to level 3 was considered clinically significant. These thresholds were defined using criteria for cerebral palsy. They don't have any thresholds for patients with this condition because it is a rare disease. If we go to the next slide. So this is a summary of the PEACE trial. This is adapted from the comparative evidence table on page 198. So it's double-blind, placebo-controlled, randomized controlled trial. They only had 32 participants because it is a rare disease, and they were randomized to receive either the pegsilarginase or a volume-matched placebo. The mean age of enrollment was around 11 years of age, and the mean plasma arginine level was 402 millimoles per liter. Mostly the inclusion criteria, they had to be 2 years and older with documented deficiency in the arginine 1 enzyme. They had to have elevated plasma arginine levels. They had to have some impairment on their functional mobility, and they had to be on a stable medication regimen to manage the condition. So this was a short trial. It was only 24 weeks, but it was followed by a long-term extension trial over 150 weeks. So the primary outcome in this trial was the % change from baseline in plasma arginine at week 24. And so the folks that got the active comparators, there was a decrease in their arginine level by 74% compared to placebo, which was only 3%. So that was statistically significant. But as I mentioned, it's debatable what the clinical significance of lowering the plasma arginine is. In terms of the trial limitations on the next slide, it was a short duration of treatment for a chronic, progressive, lifelong condition. It was a small population due to the rare nature of the deficiency. And there were some slight differences in the baseline demographics, which could increase the risk of selection bias. So the mean age for the active comparator group was 10 years of age versus the placebo-treated group, which was 12.9 years. And then there was some differences in their mean baseline plasma arginine. The active comparative was 365 micromoles per liter versus the placebo-treated, which was 472. So although the primary outcome showed a significant improvement from baseline, the secondary outcomes that assess mobility did not show statistically significant improvements. The trial may have been too short to evaluate those improvements in motor function. In the background, I cited one patient that it took 2 years to see any changes in their motor function when they were getting treatment. In terms of safety, so the most commonly reported adverse events were vomiting, fever, cough, increased ammonia, nausea, and abdominal pain. And serious adverse events, ironically enough, there was more people on placebo that had the serious adverse events than on the active comparator. There was elevated ammonia, and then encephalopathy related to the elevated ammonia, as well as vomiting. There is a black box warning for this drug regarding the risk of anaphylaxis. Hypersensitivity reactions that were mild to moderate in severity occurred in 13% of the pegzil-arginase treated patients. And they usually occurred within the first few doses, but they may occur later in treatment. So pre-medication with antihistamine should be considered. And then if patients have had hypersensitivity reactions, corticosteroids may need to be added if they continue this therapy. We go to the next slide. So the recommendation is to implement PA criteria to ensure pegzil-arginase use in the appropriate populations that have FDA-approved indications. So PA criteria start on page 202 of the packet. Our standard goals and what we're looking for PA. I didn't talk about dosing. This drug is given IV for the first 8 weeks, and then if tolerated, you can switch to sub-Q. So it's possible we would have pharmacy as well as provider administered claims. And like the other high-cost drugs, this was covered beginning 5/1, and fee-for-service is covering all the high-cost drug payments. We go to the next slide. So standard, what's the diagnosis being treated? Do they have prior fee-for-service approval for the requested drug? Is it a FDA-approved age and indication? And then we're asking, is it provided by a specialist that has expertise in managing metabolic disorders such as urea cycle disorders? And then is it a request to treat hyperarginemia in a patient that has the arginase 1 deficiency? And then we were asking that the diagnosis be confirmed by genetic testing or reduced arginase enzyme activity in red blood cells, and for them to document that. We want to make sure they're on a protein-restricted diet because that's part of the FDA labeling, that this drug be used in conjunction with a protein-restricted diet. Do they have documentation of what the arginine levels are in the past 3 months? We have number 9 in there because that was an exclusion part of the clinical trials. If they had elevated ammonia, they were not part of the trial. And then we want to make sure they're on a stable medication regimen. And then is there some documentation that they're going to evaluate the arginine levels because that's needed to determine any dosage adjustments. We'll go to the next slide. This is the renewal criteria. So if we've approved it and then they're coming back, we just want to make sure that the arginine levels have decreased, and we put in there at least 25% from baseline. And we want to also make sure that the provider has assessed adherence to treatment and that they're adhering to a protein-restricted diet. And with that, I would open it up to any questions from the P&T committee, either about the evidence or the PA criteria.
Nice job, Deanna. Any questions for Deanna on the presentation or the proposal? Okay, hearing none, we do have public comment. We have Abby Hatta, Regional Medical Director with Immedica, the manufacturer. Are you able to unmute your line? And I hope I didn't butcher your name too bad.
That's right. Yes, can you hear me?
Hear you loud and clear.
Perfect.
And the floor is yours.
Thank you for your consideration today. Again, my name is Abby Hatta, and I'm the Regional Medical Director for Immedica. As you are aware, this is the first ever approved treatment specifically for arginase deficiency, which again, there have been treatments for other forms of urea cycle disorders, but arginase deficiency is unique and it is a very rare subtype. I did want to mention this is a very thorough review of our clinical trial program, and I appreciate that. I do want to note that in the extension data, it was looked more carefully at the ability to show signs of improvement for this patient population. Obviously, the 24-week period was a very limited time, as you already mentioned, to show changes in a disease that is progressive over the lifetime. I would note that specifically when it comes to spasticity in the lower limbs, which that's really kind of where it kind of initiates in patients and is most pronounced. Then in extension data that it showed that 84% of patients eventually within that 150 weeks had improvement in the lower limb spasticity, and 42% actually had improvement down to a score of 0, which is no spasticity. So just wanted to add that in. However, we are really grateful that the committee received feedback from 2 treating physicians in the state of Oregon, and as a result, modified their criteria as appropriate based off the clinical indication, which you just reviewed. So I appreciate your consideration and the modification of that criteria. And as a result, I am happy to respectfully yield back my time, as I know you have lots to review in addition. Thank you. And happy to answer any questions.
Yeah, exactly. So appreciate your time and yielding back to the committee, respecting that. Are there any questions from the committee? All right, hearing none. Again, Abby, appreciate you showing up and providing the clinical support. So the recommendation's back up for the committee, and it's to implement the PA criteria to ensure this medication is being used in appropriate populations. Any discussion or recommendation to approve?
Do we have a motion?
Motion to approve the recommendations as outlined.
In a second?
Second.
Second.
Perfect. All right. All those in favor?
Aye.
Aye.
Opposed? Abstain? All right. Thank you.
Okay, so this is where I get to do my speed reading like I'm on the radio about announcement. We're going to go to executive session just to make sure, Dr. Bruce, you understand. We're going to move off to a breakout room. We're going to talk about confidential pricing. So stay tuned. We'll move you over there and then we'll come back out for final recommendations. So the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive session is held pursuant to RS 1926602F and ORS 4 and 4, 3561 and 2, which allows the P&T committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class. It's necessary for the committee to make final recommendations or to comply with requirements of ORS 4 and 4, 356, or 4 and 4, 353. Representatives of news media and designated staff shall be allowed to attend the executive session, and all other members of the audience will not be permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session, except to state the general subject of the session as previously announced. No decisions may be made in executive session. At the end of the executive session, we return to open session. And with that, we're going to break out. I'm going to pause our recording. All right, the recording has started again. We're coming back out of exec session. We have a handful of classes that we need to take PDL recommendations for. So I'm going to break these down into different kind of bite-sized pieces so the committee can take that and make recommendations to approve and then vote. So first, we're going to talk about the part of the consent agenda, the inhalers for asthma COPD. After review, and I'm going to break these out by each class. So it's going to start with the short-acting beta agonist. So for the SABAs, the recommendation is to make levalbuterol HFA, Xopenex HFA, and levalbuterol nebulizer preferred.
All those do we need to make a motion, Roger, or just take a vote?
I think we can just take a vote.
Perfect. All right. All those in favor?
Aye.
Aye.
Opposed? Abstain? All right, thank you.
For the LABAs, make Striverdi Respimat and arformoterol nebulizer preferred and Ceravent Discus non-preferred.
All right, all those in favor?
Aye.
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 Anyone opposed? Abstain? Thank you.
For the ICS LABA combinations, make Dulera and AirDuo Respiclick non-preferred.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
For the LABA LAMAs, make Besvespi Aerosphere preferred.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
And for the inhaled corticosteroids, make budesonide nebulizer and fluticasone HFA preferred. Make beclomethasone dipropionate AR with adapter non-preferred. Make Pulmicort, Flexhaler, Arnuity Ellipta, and Qvar ReadyHaler non-preferred.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
Next off, the Healthier Oregon policy update. We had these classes which we previously or most recently reviewed, so we're looking at just pricing and exec session. So first, for the topical antifungals, make generic tolnafate cream and powder, cycloprorax shampoo, nystatin powder, nystatin triamcinolone ointment, econazole nitrate cream, terbinafine cream, butenafine cream, clotrimazole solution preferred.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
For the antidiarrheals, make generic diphenoxylate atropine tablets and bismuth subsalicylate tablets, chew tabs, and oral suspension preferred.
All those in favor?
Aye.
Aye.
Abstain? Oh, sorry. Opposed and then abstain. I think we heard everybody already.
Awesome. For the proton pump inhibitors, make omeprazole magnesium delayed release capsules, omeprazole and omeprazole magnesium delayed release tablets, and omeprazole delayed release rapid tabs, esomeprazole magnesium delayed release tablets, omeprazole sodium bicarbonate capsules, all preferred.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
For the laxatives, make lubiprostone capsules, prucalopride succinate tablets, polyethylene glycol 3350 powder packs, methylcellulose powder, which is Citracel, and senna leaf extract chew tabs preferred.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
Nasal allergy inhalers, make ipratropium bromide spray, triamcinolone acetonide spray, fluticasone propionate spray suspension, and budesonide spray pump preferred.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
And then finally, for the ophthalmics for allergies, make ketotifen fumarate drops preferred.
All those in favor?
Aye.
Opposed? Abstain? Thank you.
Going to do a little lumping now. So for the topoisomerase 2 inhibitor class update, after review of pricing exec session, no changes were recommended to the PDL. And for the benzodiazepine focus scan for catatonia, the recommendations are to make alprazolam rapid tabs, alprazolam and Tensol oral concentrate, and Lorive XR voluntary non-preferred, and make all other benzodiazepines preferred.
All those in favor?
Aye.
Aye.
Opposed? Abstain?
For spinal muscular atrophy, make Zolgenza and high-dose nusinersen, the 28 milligram, 50 milligram vials non-preferred. Let's just take that one.
Okay. All those in favor?
Aye.
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 Opposed? Abstain?
And then finally, for the myasthenia gravis DERP report, remove PDL status for the myasthenia gravis drugs in the orphan class. That's the eculizumab, all the versions, and zilucoplan. And to make the efgartigimod alpha hyaluronidase, which I think is sub-Q, it's got the 4-letter suffix of QVFC, make that non-preferred.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
And that concludes all of the recommendations from after exec, and the P&T meeting finished about a half an hour early, but yeah, any questions or comments from the committee?
Thanks, everyone.
Next meeting is August 6th. We'll be sending out placeholders and draft materials for that meeting. Will probably be going out in the next week or two. Again, invite people to look at those draft materials. They can provide us comment before we post final documents on July 7th, but Dr. Bruce, welcome to the fray. Appreciate you joining us, and the entire committee, thank you for doing this important work. And I hope you enjoy the rest of the day.
Thanks,
Bye, everyone.
everybody.
Thank you.
Appreciate y'all.
Thank you.
Bye-bye.